central line bundle. Central line bundle is a set of actions used to decrease central line associated bloodstream infections. This is asepsis. However, we often think of the things that we pick up as part of central line as being part of the bundle. That is not the bundle. The bundle is a set of actions, and these are not optional. These are nationally recognized guidelines to decrease central line associated bloodstream infection. We put them as a 5-pointed star to help you remember what they are. The first one is a hand hygiene and surgical scrub that lasts at least 5 minutes. Use of skin asepsis with chlorhexidine gluconate. Proper site selection, which is the subclavian, but we will talk more about that when we get to that in site selection. A maximum sterile barrier, which includes covering the hair, a gown, fully bodied drape, and the probe cover. And then, most importantly, reviewing your central line every day to say that you still need it. If you don't need a central line, the safest central line is one that's not in the body. So, this all starts with planning. The first thing you need to think about when you think about a central line is, do you really need it? If you don't need a central line, again, the safest place for a central line is not in the body. The other thing is that if you're going to place a central line, you need to take your time placing it. That means doing asepsis, which is a 5-minute surgical hand scrub, and all the preparation, which cannot be done in an emergency. You can, and there are some times when it is an emergency to place a central line, but those are extremely rare. They are not in a code. In a code, you should use other vascular access methods such as EZ-IO. We teach the scale-up, scale-down protocol when it comes to vascular access, and you should always use the least invasive method of vascular access to reach your goal. Central line is the top of the pyramid. It should be your last resort. Before you start, you should ultrasound, make sure you know the location you're going, what complications you're going to have, and assure that you have the training necessary to place the central line in that patient. Always think about your patient. Again, you need to weigh the risk and benefit to placing a central line against the need for the risk of mechanical complications. In other words, if your patient is so sick that they need a central line, they may also be so sick that they can't afford a complication. It is always the right thing to do to ask for help. We always try to avoid femoral veins in the adult patient for vascular access, and we try and use the subclavian vein as often as possible. We will talk more about this in a little bit because there is a trade-off there. And we always try and use the minimum number of ports or lumens as possible in our central line. This may not always be applicable at bedside, though, as we most often place a triple lumen catheter. And then catheter length is based on the site you choose. So before you even start, you have to know where you're going, and you have to know the vessel is appropriate. So you should always pre-scan. Now, when we talk about our supplies, they are standardized across our institution. When you go to pick up your central line, there's only 2 kits that are available at bedside. One is a 16-centimeter triple lumen. The other is a 20-centimeter triple lumen. So the 2 different lengths. So you have to know your site before you pick up your kit. But everything you need is in the kit. The only things that are not included are the sterile gloves, because they are based on your hand size, and the cover for the transducer, which is near the ultrasound machine itself. So our aseptic technique, it's important to remember all of the procedures, and you learn this best by hands-on practice. The first thing is that you have to do a 5-minute surgical scrub, and this must be done in a particular way so that we take care of as much bacteria on our hands as possible. This is extremely important. What we have found is that when we have less than 7-day infections, most often it is due to an improper or too short surgical hand scrub. Sterile gloves should be worn for the insertion of both arterial and venous catheters. While this seems commonplace with central venous catheters, oftentimes we see learners using non-sterile gloves for arterial line. Just remember that an arterial line can also seed a central line and cause a central line associated bloodstream infection, but it was really from the arterial line. So we want that to be sterile too. Chlorhexidine is what we use in our institution, and for this it's a basket weave pattern and allowed to dry. It is not the circles as you use with betadine. And then a maximum sterile barrier, that means you're covering the patient from head to toe as well as the transducer. Also, you must remember that if you have a beard, you need to wear a face mask and cover your hair. Now, there's two kinds of dressings. We primarily use the Tegaderm CHG securement dressing. It has a clear patch of CHG material built into the dressing. It allows us to see through to the insertion site. This is what we use. In select instances, particularly in like the NICU and a few other locations, we may use the BioPatch. But the BioPatch is not as effective as the CHG Tegaderm dressing, and that is what we use here. Now, for a central line to be called certified as aseptic, it must be placed by a qualified inserter, that's you, once you are approved to do this, as well as being observed from start to finish by a qualified observer, which is the bedside nurse. Important thing here is that if the nurse does not certify your line, then the line must be removed within 24 hours. So what is a qualified observer? A qualified observer is a nurse that has undergone training, that understands the aseptic technique for central line placement, and is in the room to monitor you the whole time to assure that there's been no break in the aseptic technique. That means they cannot come and go from the room. They are there to watch you and to tell you if there's a break in sterile technique. If there is a break in sterile technique, this is not the end of the world. You can remediate that, say replacing your gloves or maybe replacing your gown. But you have to know this happens so that you know to remediate it, and that's what that second person's for. Again, just remember, if the nurse doesn't certify the line for any reason, then it must be removed in 24 hours. This is another reason why we don't place central lines in an emergency setting, because they will not be certified. So a few key concepts. Again, all central lines must be certified by an independent observer. That's the nurse in the room. This observer assures aseptic technique. Central lines that are not certified must be removed within 24 hours. And most importantly, you need to say you need the line every day, and once you've met the goals of care that require the central line and you can use another vascular access device, you should remove the central line. You may have to put it back in again later if that condition arises again, or a new one that needs a central line, but you should remove that line whenever that condition has resolved. So in summary, hospital-acquired bloodstream infections are a known complication from central lines, but are preventable. If you follow all of these guidelines, your central line rate for infections will be much lower and will approach zero. This is really important for hospitals because it affects our quality as well as our reimbursement. And prevention is a team effort and requires intentional practice.